Good morning, everyone, and welcome to our Friday morning TIRO MDS program. We are, as is commonly said, we are live from New York, but we have an international guest here today, Dr. Antonio Matrone, who will be presenting, and we have an outstanding discussant, Dr. Munir Ghesani, who definitely has frequent flyer points on the TIRO platform. The topic this morning are related to the European Thyroid Association guidelines for the use of radioactive iodine postoperatively in differentiated thyroid cancer. I think it's most appropriate that we review these in light of the recent release of the ETA 2025 guidelines. I would be very happy to introduce Dr. Matrone, who is a postdoctoral researcher at the endocrine unit in the Department of Clinical and Translational Sciences at the University of Pisa. He has significant experience in the management of patients with thyroid cancer. He's widely published and widely respected in the field. He will be presenting this paper that's shown here. We have, as I mentioned, Dr. Munir Ghesani, who is Medical Director and Chief Medical Officer of United Theranostics in Princeton, New Jersey. Having trained in internal medicine, nuclear medicine, and diagnostic radiology, Dr. Ghesani was the system chief in nuclear medicine and molecular imaging at the Mount Sinai Health System, where he and I overlapped for his time in New York. Dr. Ghesani has published over 200 peer-reviewed papers. He's held numerous leadership roles, including past president of the Society of Nuclear Medicine and Molecular Imaging, as well as past chairman of the American Board of Nuclear Medicine. As always, I'd like to encourage our listeners to send in their questions. I will do my best. This is always a topic that engenders significant amount of some degree of controversy and certainly some degree of discussion that I hope will follow the presentation and discussion. And so with that, Dr. Matrone, I'd like to have you share your slides and looking forward to your talk.
So good morning or good afternoon for the European listener, and thank you very much. I'm very honored to be here with you to discuss this paper. So I want to start with the first slide that is the title and the authors of this consensus. So 2022 ETA Consensus Statement, and the title is "What are the indications for post-surgical radioiodine therapy in differentiated thyroid cancer?" However, before starting with the discussion about the recommendation provided by ETA, I want to remember that over the last decades, we had a very important increase in the diagnosis of thyroid cancer, in particular of differentiated thyroid cancer and papillary histology. And this is a report that is evident in many countries in and outside of Europe. And in this slide, we can see the data of the surveillance, epidemiology, and end result program in the United States. However, when we looked at the survival rates, this remains very, very high, the 5-year survival rates, with a rate of 98.4%. However, when we divided the patients with differentiated thyroid cancer according to the staging, at the initial staging, we can see how we have a very high relative survival for patients with localized and regional disease, but the survival drops down to 50%, but only in cases of distant metastatic disease at presentation. And also in Europe, the picture of survival is very similar. However, as we can see here in this paper published in 2017, this is the Eurocare 5 study of that consists of more than 80,000 total cases in Europe, so about the 50% of the European population. And as you can see here, regardless of the type of thyroid cancer, because in this study we have all thyroid thyroid cancer, and regardless of the stage diagnosis, we have a very high relative survival rate that was 88% in women and 81% in men. And another key factor to consider is the publication in 2015 of the American Thyroid Association guidelines. This because more conservative management is advocated in patients with differentiated thyroid cancer. The 2015 ETA guidelines endorsed the active surveillance for microcarcinomas without lymph node metastasis and a minimalistic surgical approach, so the lobectomy without lymph node dissection, to treat intrathyroidal papillary thyroid carcinoma less than 4 centimeters in selected patients. And it is clear that when we perform lobectomy, radioiodine is not suggested. However, in the other cases, also in the 2015 guidelines, the guidelines suggested a total thyroidectomy, associated or not with compartment-oriented lymph node dissection and associated or not with radioiodine treatment. So radioiodine is suggested in selected cases, but which cases? And as we can see here, the suggestions are based on clinical presentation according to the histology. And the question are, is radioiodine able to improve disease-specific survival and or disease-free survival? And so the ETA suggested the indication for radioiodine treatment. And for example, as we can see here, when we talked about low-risk patients, so patients with microcarcinomas, but also patients without lymph node metastasis or extrathyroidal extension, but also with larger tumor between 1 and 4 centimeters, there are no improvement in disease-specific survival according to the literature. And also in the second category, we have conflicting data about a potential improvement in disease-free survival. So in these two categories of patients considered at a low risk of recurrence, radioiodine treatment is not indicated or not routinely indicated. In the second category, so the low to intermediate risk, in which we do not have any presence of lymph node metastatic disease. However, we have that the tumors can be larger or with a, let's say, aggressive features such as microscopic extrathyroidal extension. And also in this case, the data about the utility of radioiodine are conflicting. And also in this case, radioiodine administration can be considered on the risk of recurrent disease. Quite different is when we have the presence of metastatic lymph node in the neck. However, mainly in the lateral cervical compartment and of significant dimension. In this case, we can consider the radioiodine treatment, and we should give radioiodine in patients at high risk of recurrence, in which we have evidences of the literature that radioiodine administration can help in improve disease-specific survival and disease-free survival. But why these conflicting data about low and low to intermediate risk cases? And these suggestions derived by several papers that showed a higher rate of excellent and indeterminate response in patients at the low and intermediate risk of recurrence. Let's say we can say that when we have a patient with excellent response or indeterminate response, many of these patients will be cured during their follow-up. Conversely, a higher rate of structural persistence of the disease is associated with the tumor at high risk of recurrence. But a question I asked myself was, but why the European Thyroid Association decided to build a consensus about the indication for post-surgical radioiodine administration 7 years after the publication of the ETA guidelines? And one of the answers is probably in this survey. This is a survey published in 2022, and we have 8 participating experts, all members of the European Association of Nuclear Medicine, the thyroid committee of this association, and they were asked to participate in this survey and to answer the following question. Which is your treatment strategy decision for patients with thyroid cancer after near total or total thyroidectomy? And as you can see here, there is a almost complete agreement in giving therapy with radioiodine in patients who had T2 tumors, obviously in those with distant metastatic disease, but probably when we evaluated some patients with T2 tumors, we can also say that some of these patients can be at low risk of recurrence. However, in most of the cases, radioiodine treatment was suggested. There was also a disagreement it is more complicated for very low risk or low risk or very low risk cancer, because when we see the complete agreement is achieved only when I have a T1A tumor, so a small papillary microcarcinoma without vascular invasion, without lymphovascular invasion, and all agreed to not give radioiodine in these patients. In all other cases, many of these are low risk of recurrence, the opinion are completely discordant. And also when we evaluated a larger tumor, but not so larger T1B tumors, most of these are at low risk of recurrence. Many aspects of this survey suggested, in many cases, the use of radioiodine, of post-surgical radioiodine. So it is worth to note that the participants in the previous survey are all nuclear medicine physicians. But I want to report this data about an Italian study, the Italian Thyroid Cancer Observatory Group, in which many physicians are endocrinologists. And as you can see here, when we take the patients of this study, and there are more than almost 2,000 patients, in 61% of them, radioiodine was administered. But as you can see here, when we divided the patients according to the risk of recurrence, radioiodine treatment was suggested in almost half of the patients with low risk of recurrence, and in most cases with intermediate risk and high risk of recurrence. And another important point is, in my opinion, that at least in Europe, the management of thyroid carcinoma, mainly in its differentiated form, is managed by endocrinologists, nuclear medicine physicians, by surgeons, and by oncologists, and maybe with different points of view and different attitudes. So hence the need for a consensus statement. And in the first part of this consensus, the authors highlight that in the last year, there was an increasing incidence of differentiated thyroid cancer, mainly due to papillary histology. Most of these cancers are small papillary thyroid carcinoma. As a result, this is very important to underline, of screening bias, so the non-selective use of neck ultrasound and fine needle aspiration cytology. But about 70–80% of thyroid carcinoma detected nowadays have papillary thyroid carcinoma with excellent long-term prognosis, for whom overtreatment should be avoided. Unfortunately, the authors said for many years the management of thyroid cancer has been based on retrospective studies which may be biased in many aspects. And subsequently, they reported the three aims of radioiodine therapy. The remnant ablation aim, so to destroy postoperatively remaining, presumably benign residual thyroid tissue, to facilitate the follow-up studies, and maybe this is a guilty of the endocrinologists like me, so the use of serum thyroglobulin, but the adjuvant treatment to destroy subclinical microscopic tumor deposits that may or may not be present. And in this case, the goals of the adjuvant therapy are to improve disease-specific survival and disease-free survival. And the treatment of known disease to destroy persistent or recurrent differentiated thyroid cancer foci with radioiodine in order to improve progression-free, disease-specific, and overall survival. And it can be given either with curative or palliative intent. And lastly, the authors underline that in the field of oncology, the real benefits are defined as improvement of overall survival or disease-free survival and a good quality of life. So let's talk about recommendation 1. The recommendation 1 is a general consideration about the decision for postoperative radioiodine treatment. And the author said that this decision should be taken based on initial prognostic indicators for thyroid cancer-related death, but also for recurrence, including among others the surgical and pathological report, and on the result of serum thyroglobulin measurements and neck ultrasonography obtained after surgery. Regarding the indication for thyroid cancer-related death, TNM system, this is the 8th edition, is most used and reliable. And in this table, we can see how the higher the staging, the more likely the patient is to die from the disease. And this is true mainly for patients over the age of 55. And this is a very nice paper published in Thyroid in 2017, in which the authors reported that disease-specific survival is associated with the T stage of the tumor. However, when they reclassified the patients according to the TNM stage, so stage 1, 2, 3, and 4, you can see how the stage 1 patients are better stratified into the stage 1, so they did not die from the disease. However, we should remember that the risk of persistent or recurrent disease in our cancer, in our differentiated thyroid cancer, is higher than the risk of cancer-related death. And the literature in clinical practice highlight this, and for this reason, the 2015 ETA guidelines, and very recently revised in 2025, highlighted the importance of classifying patients according to their risk of recurrence, in a continuum that is very useful for managing these patients in clinical practice, including also the suggestions, as I showed you before, about radioiodine administration. But already in 2015 ETA guidelines and also in the ETA consensus, the author, let's say, strengthened the concept of the post-operative evaluation to evaluate the disease status. And they said that regardless of the risk category, the result of neck ultrasound performed in the post-operative setting, so 2 weeks to 2 months and after surgery, and serum thyroglobulin measurement, preferably more than 6 weeks or more after surgery, have a pivotal role in patient selection for radioiodine therapy. Clearly, if there is the evidence of a biopsy-proven lymph node metastasis or a stimulated postoperative thyroglobulin value above an institutional cutoff, they underlined in several parts of the paper the institutional cutoff, or they said also that there can be let's say, a value of above 2 nanogram per ml should lead to selection for radioiodine treatment. But whenever risk factor and patient selection for total thyroidectomy and radioiodine are evaluated, wide differences between countries as environmental factors, preclinical care, and healthcare should also be considered. And sorry. In this regard, I would like to show you this paper that is also included in the 2025 new ETA guidelines that we wrote in 2017, even regarding the postoperative stratification of low and intermediate risk differentiated thyroid cancer. In this paper, we evaluated 505 consecutive patients with differentiated thyroid cancer at a low and intermediate risk of recurrence without the presence of interfering thyroglobulin antibodies. All these patients were treated with radioiodine, most of these patients with 30 millicurie of activity of 30 millicurie. And you can see in this picture that we divided these patients according to the value of thyroglobulin and postoperative assessment. And in about 30% of the cases, 3-4 months after surgery, thyroglobulin was already undetectable, so the group A. And after we have the group B, in whom thyroglobulin was between 0.1 and 1 nanogram per ml, and group C, in which was above 1 nanogram per ml. All patients were submitted to radioiodine therapy, and the aim of this study was to evaluate in how many patients the administration of radioiodine was able to detect radioiodine metastatic disease. And these are all our metastatic patients of our cohort, about 5% of all of the whole cohort, because we have 27 metastatic cases on 505 patients. But when we evaluated the metastatic disease detected only by radioiodine treatment, we have that this is evident in only 7 cases on 505. So 1.4% of all our initial population. Since most of the cases had lymph node metastasis, and most of these lymph node metastases had already detected by neck ultrasound. So we conclude that not only thyroglobulin, but also neck ultrasound is very important for the post-operative restratification of patients with low and intermediate risk of recurrence, and that in the low and intermediate risk cases, the rate of radioavid metastatic disease is very low. So moving to the second recommendation, the authors stated that in patients at high risk of recurrence, the use of radioiodine therapy as a adjuvant treatment or treatment of known disease is indicated for patients in the high risk of recurrence category or with known structural disease. In this setting, high activity of radioiodine are preferred over low activities. And they reported that this very nice study published by the group of Professor John Klass in TIRO in 2006. In this paper, when analyzed about 3,000 patients with differentiated thyroid cancer. However, when they focused their attention on the high-risk patients, in the overall cohort, improved overall survival was significantly associated with either neither NTT is near total thyroidectomy or total thyroidectomy and radioiodine therapy. And a benefit in the last columns is also observed for disease-specific survival in high-risk patients who performed the radioiodine treatment. However, most concerns are about patients with more concerns are about patients with intermediate risk of recurrence, because they said that the intermediate risk category radioiodine therapy may be indicated and should be tailored according to individual cases. So they analyzed that in some patients there can be a great benefit of radioiodine treatment. So the patients with advanced age, those with aggressive histologies, those with increasing volume of nodal disease or extranodal extension of the tumor, and those with multiple N1 disease or lymph node metastasis outside the central neck. Conversely, in those cases with minimal extracellular extension or few microscopic or few lymph node metastasis, and also in the intrathyroidal papillary thyroid carcinoma, also if BRAF V600E mutation was present, the benefits of radioiodine are controversial. However, in these cases, again, the postoperative evaluation with thyroglobulin and neck ultrasound can be safely used to decide if radioiodine should be performed or not. But why these controversial opinions? Because the data about intermediate risk of recurrence patients are controversial. And as we can see here, we have the authors of the consensus cited this paper published in JCM of the group of Ruel, and they take into account the patients of the National Cancer Database, all at intermediate risk of recurrence according to 2015 ETA guidelines, but for example, aggressive variant of PPC, the told cell, were excluded, and they divided the group according to those who received it to those who did not receive therapy with radioiodine. They had a mean follow-up of 6.8 years, and the survival rate was very similar between the two groups. However, the overall survival was significantly higher when they applied the statistic analysis in patients who performed the radioiodine treatment. And this is true for the whole group of patients, but it is but also for patients, and this is more evident for patients older than 65 years. However, the authors themselves reported that the interpretation of this result is challenging, given that patients who received radioiodine treatment had a significantly higher burden of metastatic lymph node disease and rates or tumor multifocality, which may reflect the selection bias towards patients with higher risk of disease. That disease recurrence is not captured in this database, but in my opinion, overall, that the authors analyzed the data about overall survival and not disease-specific survival. Regarding recurrence, data are more consistent. I like to show this paper of Kim, published in 2016, because this is a monocentric study of 8,000 people, about 8,000 people, most of them treated with radioiodine treatment, all at intermediate risk of recurrence. And they did not find any difference in recurrence-free survival rate between patients treated and not treated with radioiodine. And also when they searched for an advantage of administering radioiodine based on clinical features, also, for example, as you can see here in this table, in BRAF positive patients, they failed to find any feature associated with the advantage of radioiodine administration in terms of recurrence rate. So I give you some my consideration about discordant result in these patients, but mainly because we have the lack of prospective randomized data, but above all that there are too much different tumors classified into the same risk of recurrence with various clinical behaviors grouped in a single category. We have lacking data about postoperative evaluation. We have different activities of radioiodine used and different follow-up strategies and time. And recommendation 4 is for the patients at a low risk of recurrence. And so in these cases, the authors reported that the benefit of radioiodine therapy is a matter of intensive scientific debate, and the decision on whether to perform radioiodine therapy should be based on the presence of individual risk modifier. Why? Because there is a controversial discussion among experts on whether postoperative radioiodine administration is useful or not in low-risk patients. But because the risk of disease-specific deaths in this population of patients is less than 1%, but also the presence of recurrent persistent disease is very low, 2-3%. And it is very hard to imagine that the retrospective studies can demonstrate any benefit in terms of disease-free survival when the overall risk is very low, 2-3%. But based on the literature of the past decade, the results are not consistent. So some other authors report the benefit of applying radioiodine even in patients with microcarcinoma. And the authors reported this study published in 2020, this is a review, in whom the role of radioiodine in low-risk patients was investigated, according to the results of 11 studies. These are the studies the author included in this systematic review, and the reported outcomes, and you can see, are different for each paper. We can have reported outcomes as recurrence-free survival, as overall survival, as disease-free survival. And the authors conclude that when they evaluated the study only on microcarcinomas, so small papillary thyroid carcinoma, less than 10 millimeters without metastasis patients, 2 on 4 studies showed a statistically significant benefit of administering radioiodine therapy. And also when they evaluated the non-microcarcinomas without distant metastasis, so a low-risk group, 4 on 6 studies showed a statistically significant benefit of radioiodine therapy. So they concluded that the next question is which patients will benefit from radioiodine therapy. Because somewhat surprisingly, and contrary to the general opinion in the field, in the present study, we even found 2 studies providing at least some results indicating a positive association between radioiodine therapy and patients' relevant outcomes in microcarcinoma cases. However, the authors of the consensus finally recommended that radioiodine remnant ablation is unlikely to improve the outcome in papillary, unifocal, or multifocal microcarcinomas in the absence of other risk features, and so radioiodine should not be used in these patients. However, they applying the postoperative paradigm, so low-risk patients with postoperative detectable serum thyroglobulin, if above the institutional cutoff, or with abnormal ultrasound findings, have a higher risk of recurrence, and radioiodine therapy may be considered, although they underlined that there is no evidence that it can improve disease-free survival. In contrast, we should remember that the risk of persistent disease is very low, 1.5%, when serum thyroglobulin is undetectable on LT4 treatment. And these patients will potentially not benefit from radioiodine ablation. In addition, even if no radioiodine therapy can be given after surgery, clinical recurrences can be treated successfully later on. I want to give you an insight about 2 very recent papers published in 2025, prospective randomized clinical trials, Estimable 2 and ION, that confirmed that there is no need for the use of radioiodine routinely in low-risk differentiated thyroid cancer patients. Recommendation 5 is about preparation for radioiodine administration. And the author said that recombinant human TSH during LT4 treatment should be the preferred method of preparation for radioiodine administration. We know very well that there are 2 randomized non-inferiority trials published both in 2015 12, in which there was the comparison between low and high activities of radioiodine, each in combination with either recombinant human TSH or thyroid hormone withdrawal. And as you can see here, when the outcome was the complete thyroid ablation, so the ablation rate, there is no different in the preparation to radioiodine if we use recombinant human TSH or LT4 withdrawal. However, we should keep in mind that it is okay that we have no differences, but the preparation with the recombinant human TSH is associated with an impaired quality of life and a decrease in whole body radiation absorbed dose and a reduction in the duration of hospitalization. However, we should keep in mind that the recombinant human TSH is approved for, let's say, ablation with any reactivity in the United States and in Europe for any patients except those with distant metastases. So we can use recombinant human TSH in patients that fall within the registration level. Recommendation 6 is about the activity of radioiodine for post-surgical remnant ablation. And the same studies were cited to tell us that activity of 30 millicurie are equally effective as higher activities for ablation of presumably benign thyroid remnant. These are the same studies that confirm this recommendation. And recommendation 7 is about diagnostic radioiodine scanning before radioiodine therapy. So whenever a decision to perform postoperative radioiodine therapy needs to be taken, a diagnostic scan is not routinely required. There is an increasing trend to avoid the diagnostic scan because of its low impact on the decision to treat and because of the possible stunning effect of radioiodine on thyroid remnant and metastasis. It is recommended, obviously, to perform a post-therapy whole body scan within 1 week after the administration of RAY. Several papers show that it may disclose the presence of unsuspected metastatic foci in 10-26% of high-risk cases, and in some of the low and intermediate risk cases. And whenever possible, a single photon emission computed tomography, SPECT-CT, is to be performed to better define the neck uptake to distinguish the thyroid remnants from locoregional lymph node metastasis. And the last recommendation is about a low iodine diet before radioiodine therapy. A low iodine diet may be prescribed, but its utility is not demonstrated unequivocally. However, the author underlined that any iodine-containing drug should be avoided. We know very well that the exposure to excessive amounts of stable iodine may influence the uptake. However, no prospective study has ever determined the cutoff over which interference may actually occur. There is conflicting evidence on the impact of low iodine diet on the remnant ablation success, and the measurement of urinary iodine excretion when available may help in detecting the few cases with a significant iodine excess. So the conclusion of this paper are that radioiodine therapy should be based on initial prognostic indicators for thyroid cancer-related death and recurrence. And I think that all of us in clinical practice use the ETA risk stratification system, that the use of radioiodine therapies as adjuvant treatment or treatment of no disease is indicated in the high-risk group. In intermediate risk category, radioiodine therapy may be indicated, but according only to individual risk factors, and also in low risk patients, in those few cases in whom we decided to administer radioiodine, this should be based on individual risk modifier. Recombinant human TSH is preferred for TSH stimulation, and activities of 30 millicuries are equally effective as higher activity, but for remnant ablation. Before radioiodine therapy, a diagnostic scan is not routinely required, and before radioiodine therapy, any iodine-containing drugs should be avoided, but no indication are about low iodine diet. And I want to thank you for your attention.
Okay, thank you so much for an excellent presentation. It is not easy to summarize this very complex and controversial topic in such a short time, and especially since you have contributed so much to the literature in the area of that controversy. So I appreciate all the efforts that you have made and given our audience an excellent overview of the status of when the radioiodine therapies are
indicated and breaking it down based on the risk stratification of low, intermediate, and high. I will summarize some of the slides, and then I also will compare the differences between the ETA 2022, ETA 2015, as well as just recently published ETA 2025. And I have created a few tables to really highlight similarities and differences between them. Obviously, when you look at this risk stratification-based approach, it reminds me of more than 100 years ago where Bayes' theorem came out. And then several scientists in the practice of medicine started to introduce that concept in medical practice as well. And those of us in nuclear medicine practice based on nuclear cardiology approach of Diamond and Forrester, that was very well applied in the practice as well. It also reminds me of the fact that there are still controversies. You can see here that there is still 41% of the group favoring I-131 in the low risk, and then about a minority not suggesting it even in the high risk. And that brings up the point of those of us who have participated in this large trial of PIOPED in the lung scans in the pulmonary embolism assessment in late 80s and early 90s. And what was interesting and what was very similar to these data is that in that trial, it was also shown that once you have a very high probability of pulmonary embolism, there was a much higher degree of consensus. But the low probability of pulmonary embolism had a wide range of inconsistencies. And this reminds me of the similar work that we had done in the assessment of pulmonary embolism. So going into the indications in the differentiated thyroid cancer, as Dr. Matrone very clearly summarized, that the incidence of differentiated thyroid carcinoma is increasing mainly because of the papillary histology. And this is both within and outside of the Europe. And there's no doubt about, and there's no controversy about the fact that a large number of these are detected because of the imaging-based screening bias. And then 70 to 80% of these nowadays have PTC with very excellent long-term prognosis, where overtreatment should be avoided. First, do no harm. And then, unfortunately, as he mentioned, there is a need for there's need for more prospective studies because these data often are coming from retrospective studies. The practice of radioiodine treatment in the thyroid cancer is now more than 8 decades old. And we had some pioneers like Mazafari and others who decided to approach this in a prospective basis. But as we go more complex into the risk-based treatment approaches, as well as multiple tumor mutations that are now available for assessment, I think it highlights the need for additional prospective studies in addressing the areas of controversies, which were summarized by Dr. Matrone. So if you look at the key points about the estimated thyroid cancer cases in 2025, is that 2/3 of these will be localized, 2.2% of all cancer cases, but only 0.4% of cancer-related deaths. So obviously this is a very important paradigm we need to keep in mind. 98.4% overall survival, but when you look at the localized disease, that jumps up to 99.9%. So any intervention that we do, we may feel very comfortable that our intervention helped, but obviously based on the Bayes' theorem and pre-test likelihood, that intervention may not necessarily have contributed to the better outcome of the patients anyway. The other point is about the postoperative disease status, and this is an important point. If we decide not to treat, that doesn't mean that we don't consider any subclassification of patients who may have higher risk that we may not have recognized upfront. And that gives us the opportunity to look at the neck ultrasound in the postoperative setting, as well as some surprisingly high serum thyroglobulin measurement performed more than 6 weeks. That may have a pivotal role in those who were initially deemed to be not candidates, but now you are picking them up, and then you're you're selecting that subgroup of patients who may benefit from the radioiodine therapy. And so that would bring us the idea about the risk-based role of pre-op imaging, where can we identify those patients, and I'll show you in the subsequent slide that Dr. Matrone mentioned about those 27 patients out of more than 500 who were found to have metastatic disease. Is there a way to use the multi-pronged approach, including some of the mutation combinations that would benefit from more appropriate preoperative imaging? But nonetheless, he does mention that whenever risk factors and patient selections for total thyroidectomy and radioiodine are evaluated, there are still wide differences between the countries. And environmental factors, preclinical care, and healthcare access, all of them should be considered. And here's what I was referring to about these 27 out of more than 500 that were found to have metastatic disease. Is there a way of very selective approach using risk stratification, but in addition also the tumor mutations to prospectively identify those who may have more likelihood of metastatic disease? And then recommendation 2 about the high risk of recurrence. It is very critical point here that if you decide to treat for adjuvant therapy, then 1100 becquerel may not be very suitable. It works for remnant ablation, but for adjuvant therapy, it should be 37 megabecquerel or higher activities should be recommended. The other one is recommendation 4, patients with low risk of recurrence. And there's a controversial discussion about whether post-operative I-131 administration will be useful. But as I will show you later on, based on the literature of the past decades, the results are not consistent. And we will compare in a table the 2015 ETA, 2022 ETA, and then 2025 ETA guidelines. There's clear consideration about the discordant results in the intermediate risk. There are too many tumor types, as he highlighted boldly in his slide, about combination of multiple tumors mixing up the assessment and grouped all into a single category is an important factor to keep in mind. Regarding the recommendation 5, preparation for radioiodine therapy, there is no doubt about the benefit of RHTSH. And he pointed out very well, in addition to all the other benefits, that there's a decreased duration of hospitalization. Now, this is something that used to be practiced in US as well, giving the radioactive iodine at a higher activities, administered activity as an inpatient. But in the late 90s, the Nuclear Regulatory Commission rulemaking allowed patients in US to be treated even with the higher doses of administered activity, as long as you ensure that any encounter gives the radiation exposure to the family members and work setting below a certain threshold, and then even 20% of that threshold for pediatric population. And as long as you are able to do that in US, these patients are getting treated as an outpatient. But important point, he mentioned that in Europe, where majority of the patients are hospitalized, that RHTSH also helps in decreasing the rate, the days of the hospital stays as well. Regarding the recommendation 7, scanning before the radioiodine therapy, he highlighted that there's increasing trend to avoid scan, and there is some controversy about the stunning, but this is something that is not recent. This controversy of stunning has been out there for many decades, and there are ways to circumvent that, including, as he mentioned, the availability of I-123 or even I-124 PET-CT. That would be ideal, but if not, then the recommendation is to use lower doses of lowered administered activity of I-131 to avoid that stunning effect. And he highlighted very appropriately that the SPECT-CT should be a very important aspect of post-therapy imaging, not just planar, because we have found a number of examples where not only it highlights and avoids any false positive, but even allows us to have higher sensitivity of detection for very subtle lesions that may not have been seen on planar imaging alone. So let's look at now the comparison of 2022 ETA, 2015 ETA, and 2025 ETA guidelines. And I'll first show the stunning, but then I'll also show the similarities and differences in the risk-based recommendations for radioiodine therapy. So one theory suggests that the stunning may be due to partial ablation, meaning it's a favorable thing that some of the cancer cells that were addressed with the low dose iodine, low administered activity of iodine 131 may have in fact become necrotic, and as a result, you don't see them on the subsequent post-therapy scan with a higher administered activity. But there's also some concern that there may be temporary suppression or reduction of iodine transport through the sodium iodide transporters, and that may be due to the radiobiological effect of it. That's where I think that the lower administered activity will be important, and that's usually the standard of our practice whenever we perform the pre-therapy scans. The agent, this is what I was summarizing, that they recommend 1.1. In our case, we use 2 millicurie or less of the administered activity. And most importantly, there is no consistent evidence that stunning significantly hinders long-term therapeutic outcomes like overall survival or recurrence-free survival. Again, there is a need for a prospective trial to address this, but at least in the literature, there is no such data that show that even if the stunning may potentially occur, there is no impact on the long-term therapeutic outcomes of these patients. So the practice recommendations, ATA and ETA, note that increasing trend to avoid the scan on a routine basis, but it should be lowered administered activity of I-131 when the scan is performed. In the few remaining slides, let's look at the differences in the guidelines amongst the three recommendations. So the low-risk patients, not routinely recommended in all three of them. Some subtle caveats or modifiers are that for the ATA 2015, not routinely recommended for less than 1 centimeter. For ATA 2025, applies to patients with total thyroidectomy, not recommended for papillary microcarcinoma, and low to intermediate risk, it may be considered after the total thyroidectomy. For the ETA 2022, as Dr. Matrone summarized, that abnormal neck ultrasound and high thyroglobulin may indicate the need after the fact in the patient population who may have high-risk features or unsuspected detection of disease. For the intermediate risk, ATA 2015 strongly considering adjuvant therapy after thyroidectomy in the intermediate risk level differentiated thyroid cancer. And the single intermediate risk category covered a wide range of 5 to 20%. That has been in the 2025 has been further divided into low to intermediate or intermediate to high. And that would become a subgroup of patients in whom a higher likelihood of administered activity of I-131 may be beneficial. As Dr. Matrone mentioned in the 2022 guidelines, there's a subgroup that is identified based on extranodal disease, increasing volume of nodal disease, multiple N1 nodes, and the lymph node metastases outside of the central neck. And in the high-risk group, routinely recommended radioiodine therapy after total thyroidectomy based on ATA 2015, also ATA 2025, and also recommended for initial diagnosis of differentiated thyroid cancer with distant metastasis. So this is upfront distant metastasis detection. And as Dr. Matrone mentioned in 2022, it also recommends in the high-risk group. So in conclusion, as he mentioned on these slides, these are all making sense. In the low-risk patients, risk modifiers, yes, but generally de-emphasized. And he showed that there's still a wide range of recommendation in the low-risk patients for radioiodine therapy. Recombinant TSH obviously makes sense as he summarized it. Activities of 1110 megabecquerel effective as high activities for remnant ablation. This is becoming increasingly more common in the practice. And then before iodine therapy, diagnostic scan is not required. But the future development here would be see if we can identify a subgroup of patients who are likely to be hibernating some undisclosed distant metastatic disease. The other thing is in the ETA 2025, postoperative I-123 or low dose, again, emphasizing that smaller administered activity of I-131 may be considered for patients undergoing radioiodine treatment prior to therapeutic administration to help guide treatment planning. And then a guideline recommends that these scans may be helpful in retained activity in the thyroid bed, as well as presence of regional or distant metastatic disease. And what is the subgroup? So the detection of very large thyroid remnants may suggest additional surgery. Detection of insignificant thyroid remnant may mean that radioiodine therapy may not be necessary. So identifying the group of patients who may have different management implication. And then obviously, if we find clinically unsuspected disease or distant disease, then it makes a difference in the utility of radioiodine therapy. So the last recommendation is before radioiodine therapy, any iodine-containing drug, and particularly high concentration of iodinated contrast for CT scan should obviously be avoided. So that summarizes my assessment, and thank you again, Dr. Matrone, for a very informative Journal Club discussion.
Great. Munir, thank you so much. I really appreciate it. And Antonio, thank you. Much appreciated. We do have a number of questions from the audience. The first one actually relates to thresholds of post-surgical thyroglobulin. And one of the things I found somewhat confusing in reviewing the recommendations was this deferring to institutional levels. And perhaps you can just comment on that. It seems incongruous that you would have guidelines that apply across different institutions and yet defer to institutional levels here.
Yeah, this is a very important point. So I can start from the 2025 ETA guidelines, because if we look at the 2025 ETA guidelines, they said that if you have a patient treated with total thyroidectomy, but not with radioiodine, if you have a thyroglobulin less than 2.5, the patient is considered as cured. Okay, so this is a cutoff that is important to keep in mind when we decided to perform or not radioiodine ablation. I think that the authors emphasized the institutional cutoff because there are several methods of thyroglobulin evaluation. So it is important to test, for example, also the presence of interfering antibodies, the cutoff, let's say, of interfering antibodies on thyroglobulin. That is important to test in your lab because you can have several different cutoffs. So I believe I can say you and I can answer to the first question that we do in the clinical practice. So we, starting from 2016, we have had a weekly dedicated outpatient clinic for the postoperative evaluation, 3 to 6 months after surgery. And all patients at low risk, and most of these at intermediate risk of recurrence, were evaluated with clinical visits, neck ultrasound, and performed evaluation of thyroglobulin antibodies, and TSH. All in our institution. Okay, so we have a let's say evaluation of thyroglobulin and thyroglobulin antibodies very reliable. So in our experience, it is very difficult that patients with thyroglobulin less than 5 perform the radioiodine treatment. Okay, this is our, let's say, institutional cutoff.
Okay, interesting. Munir, do you have a comment on that?
Yeah, I mean, as Antonio mentioned, that the 2025 guidelines are going for the 2.5. Many institutions, and you're correct, Mark, that it should not be institutional based, but I think there are local practice variations as well as the calibration of the lab levels that are probably also influencing that recommendations. In our practice, we look at that level of 2 to decide the risk stratification for potential residual disease. But yeah, you're right. That's the available practice pattern with the variations amongst the institutions.
Okay, thank you so much. One of the questions from our audience relates to molecular profile and how specific mutations affect the decision on RAI therapy? Antonio and perhaps Munir to follow, do you want to comment on that?
Yeah, in our experience, we did not evaluate routinely the molecular profile, in particular of low-risk cancer. And we recently published, for example, the paper in patients with microcarcinoma and active surveillance. And we had that many of these patients had BRAF V600G mutation, and they are stable over time. So, for example, the presence of the most common mutation, BRAF V600E, is not an indication for performing or not radioiodine treatment. Conversely, in several cases, for example, in children in which for the fusions, rapid TC fusions are very common, the irradiated children, and it is important that because they have often radioiodine metastatic disease at lungs, and so the mutation is associated in this case with a metastatic disease. However, in clinical practice, and particularly in patients with low and intermediate risk of recurrence, we did not routinely use molecular based approach for performing radioiodine treatment.
Yeah, thank you. This is for the young investigators who are in the audience or who may be listening to this recording later on. I think this is a shout out to really work on refining these recommendations. As Antonio mentioned, that BRAF V600E alone is, it's not that much of a value, but there are data that if you have a combination of that plus TERT, for example, then things change. And, it's not a simple determination based on incremental risk. There's also a concern about the lack of potential radioiodine uptake in certain mutations. So even though the risk stratification may become higher based on a combination of molecular markers, is the administered activity of I-131 going to be effective or not? And I think having the approaches that not only guide us in more refined risk stratification, but also assessing how the radioiodine uptake in those combination of mutations really influences the effectiveness of iodine therapy.
So that seems to be a real, somewhat of a disconnect here, recommending it for aggressive histologies, such as tall cell variant, poorly differentiated, but with an acknowledgement that the likelihood of iodine uptake is going to be significantly less here. So how do you balance your desire to do more with the likelihood of ineffective therapy here?
Right. So I think there's some potential benefit of here the FDG PET-CT as well. So if you have a certain combination of mutations that you know that there is a likelihood of lower sodium iodide importers concentration, can you then pick that up with the FDG PET-CT? And currently our society has given a grant for multiple molecular profiling using single exam. This is a device that is being considered. And, let's say down the road in the future, if you're able to assess multiple markers in a single imaging exam, you reduce the cost, you reduce the patient visits for multiple imaging, and yet you can provide a full molecular profile. What is the likelihood of still expression of sodium iodide importers versus GLUT1 transporters on the cell surface? That can guide not only the decision to treat, but just this week I had a patient in whom the recurrence was predominantly FDG avid, and there was hardly any radioiodine uptake. And that patient clearly was a candidate for surgical resection, not a radioiodine therapy for known recurrence of thyroid carcinoma. So I think appropriate imaging with a combination of molecular markers in less frequent examination, possibly in a single exam, would make a big difference.
So
this can be a great idea.
But you're talking about doing imaging with multiple modalities post-surgical or pre?
It would be depending on the risk factors, right? So if you have a very high risk patient, pre-surgical, you can't do the radioiodine scan because you have to wait for the post-thyroidectomy. So technically, you can do FDG PET upfront to see if you find aggressive metastatic lesions. But for iodine scan, you have to do that in the postoperative setting.
Sure. Okay. Unfortunately, we are up against the 9 o'clock hour here. And I apologize to our listeners who sent in questions that I did not get to. We do appreciate sending those questions in. Thank you both for really a wonderful discussion on an extremely difficult and controversial topic. I'm not sure if by the next round of guidelines we will have clarified all of this. One of my questions was related to information gaps here or research gaps that we need to focus on, but that's a topic for another day. Thank you both, and thank everybody for listening. And I do want to just put in a plug for our next week's presentation, and also Voices of Wisdom podcast that we strongly encourage you to tune in and listen to that. Thanks, everybody, and have a great day here.